who is in the College of Clinical and Rehabilitative Health Sciences. She's professor and clinical supervisor and has been here at ETSU since 2002. She completed her Bachelor's of Science and Master's of Clinical Science in Speech-Language Pathology at the University of Western Ontario, and completed her Ph.D. training in Speech-Language Pathology at the University of Kansas. She teaches a number of graduate and undergraduate courses, specifically looking at and teaching, I guess, childhood language disorders and language development in general. She holds a Distinguished Faculty Award for Research through the College of Clinical and Rehabilitative Health Sciences here at ETSU. She's also the Associate Editor of Language, Speech, and Hearing Services in Schools. She's in a number of professional organizations, to name a few: the American Speech Language Hearing Association and the Tennessee Association of Audiologists and Speech Language Pathologists. She also has a large body of publications that, I guess, in large part look at childhood developmental and speech language disorders in children. And today she's speaking with us about neonatal abstinence syndrome and the developmental outcomes of that. So thank you. Welcome.
Thank you, and I want to thank Dr. Moser for inviting me to present today. Let's see. Is that good still? Can you, is it coming out? Let's see. There. I got interested in this area of pediatric problems. I've been working on the interprofessional follow-up clinic for babies discharged from the neonatal intensive care unit at JCMC since 2002. And a couple of years ago, what we noticed was that babies in the NICU, there was a higher incidence of these babies who had NAS, and they were starting to come into our clinic. And then the numbers were starting to get larger and larger, and our clinic really for that couldn't include that population because of the demands on resources. We've been trying to develop a parallel clinic specifically for these kids, but funding has been the issue. So I became interested in that. At the same time, the College of Public Health got a large grant to work with adults, children, and the problems of opiate addiction in the area, and became involved with that group. Since then, I've gotten an RDC from ETSU to start implementing an intervention program with moms and who may or may not have kicked their habit and their babies within the first year of life, to start giving them, helping the baby set the foundation for communication while we had neuroplasticity on their side, and also working with the moms and hoping that attachment and bonding and parenting skills would improve through this program as well. So that's ongoing. And as part of all that, I had to really start to delve into what was happening in our area and what were the consequences of this for babies with NAS. And that's what I'm going to share with you today. So let me start with what's happening around. Oh, I do not have a financial interest arrangement or affiliation with one or more organizations that could be perceived as a real or apparent conflict of interest in the context of the subject of this presentation. So what's happening here? This is a map of the health districts in Tennessee. We are represented by the purple up in the corner, which includes the Northeast and Sullivan Health Departments. And here is the what's happening right now in Tennessee. The Department of Health for the state has been collecting data for the last 3 years on drug-dependent newborns and newborns with neonatal abstinence syndrome. As you can, their chart had the last 2 years. I added the red line and the yellow line to give you some perspective back to 2013 and 2011. And you can see that the incidence has been rising. estimated 2011. 2013, they really started collecting better data. It seems this year, fortunately, to be evening off so that the 2015 cases and the 2014 cases up to this point in the year are about the same. If I can draw your attention to, oh, wrong button, to the Northeast and Sullivan County, you can see the percentages of newborns born in our two areas for the whole, compared to the whole state of Tennessee. We have about 24.2% of the reported newborn babies with NAS in Tennessee, and that, to put it in perspective, we have about 8% of the population of Tennessee, and we've got about 24% of the babies. The next highest area are our neighbors to the east in the East Tennessee and Knoxville area. Their percentage is even higher, but of course they have a higher percentage of the population as well. And I will be getting back to these numbers later in the presentation about the different sources of maternal substance abuse as reported by the moms or by their tests. So the incidence of maternal use has been increasing. There's been a 4.7-fold increase in maternal opioid use and 2.8-fold increase in NAS. And as you can see, the costs of this are going up. So babies, on average, the costs for the babies with NAS, even compared to our premature babies, who also take an awful lot of our resources, our babies with NAS are outstripping them versus typical babies. So it's costing our health system quite a bit. Watch Tennessee. So this is the 99 stats talking about primary non-heroin opiate synthetics admissions rates by state. And I'm going to give you a little time lapse based on this statistics from the Virginia Department of Health. So just keep an eye on that. So here's what's happening. As the numbers go up, things get redder. And so by 2009, we are among the highest rates in the country. If you look at it another way, the USA is #1 in the world, yay, for consumption of opioids per capita, and twice as many as the next highest country, which is Canada. And you can see even within the United States, Tennessee is right up there at the top. We're #2 of opioid prescriptions per 100 persons and for benzos per 100 persons. So we're #2 and #3 in the nation. When we see, again, you can see, I keep messing this up. You can see again, Tennessee is amongst the highest in amount of prescription painkillers sold, and as the rates of painkiller sales go up, so do deaths and treatment too. So let's talk about mom's choices for substance abuse, misuse, and abuse. These percent numbers are the ones from that screen I showed you earlier. So you'll notice these numbers don't add up to 100 because moms would report more than one type of drug use as part of what they're doing. So supervised replacement, we're talking about what's happening under physician supervision of methadone, buprenorphine, and the combination with naloxone, which you may know by Subutex and Suboxone. That comprises about 60.9% or 61% of what moms are reporting that they were taking during pregnancy. Supervised pain therapy, and here are the common drugs that they report or that are discovered in their system, account for about 10.7% of their reports. Again, supervised and prescribed drugs for psychiatric or neurological conditions that they may be getting as part of their treatment for a variety of conditions. So that's what's supervised and prescribed. Then we get into the non-prescribed drug use. And you could see that non-prescribed prescription drug use, our mom's drugs of choice include oxycodone, hydrocodone, benzos, fentanyl, amphetamines, and codeine. And then we get into the non-prescription substances. So together, those make up about 56% of the moms are reporting non-prescribed drug use during pregnancy. Okay. So let me talk a little bit about who these mothers are. Dr. Tim Smythe, who is one of our local physicians working with moms with addictions, indicates that his statement was research indicates 99% of mothers of NAS babies have been abused in their own lives, and they're still looking for the other 1%. So in his contacts with mom, he comes across very few that don't have a significant history of abuse. It's a complex population. Their childhoods tend to be disorganized and disruptive. They've had little supervision and had a lot of adult responsibilities placed on them as children. There's early exposure to drugs. As we were talking about, emotional, physical, and sexual abuse is very high, and victimization as children and as adults tends to be high as well. Once they get into adolescence and young adulthood, they're having difficulties with addiction. That starts young. They have inconsistent education and a high dropout rate. They suffer from poverty. They need the money for the drugs, so they date a lot or overtly engage in prostitution, and there's high rates of illegal activity and theft. And at this point, Murphy and Rosenbaum in 1999 did an intensive kind of qualitative case study of moms back in the 90s who were suffering from cocaine addictions. And they produced lots of stories. And I want to read one of them to you now to give you a picture, because I'm not sure that it's all that different with our moms on opioids than what was happening then. So here's one story that they told. Krista's mother died when she was 8 years old. She had never known her father, and with her mother's death, Krista and her half-brother became orphans. Her grandparents reluctantly took in the two children. Krista felt they resented her half-brother, whose father was Korean. Her grandparents complained about having to take a half-breed into their home. When Krista was 9 years old, her mother died, and she began smoking marijuana. She remembers one incident very vividly. I was 9 years old, and this girl was 16 years old, and she asked me to smoke some pot, which I thought was just pot. And we were up at the fort, this little thing in the field. And I smoked this thing I thought was just pot, and it wasn't. I didn't know what it was at the time. I had no idea what was wrong with me. Something was wrong. A few years later, when I tried PCP, I realized that's what it was, okay? I was 9 years old, and this girl, she just simply didn't want to get high by herself, and she didn't tell me what she was giving me. She thought it was funny or something. When Krista was 16, she met her children's father, who introduced her to cocaine and heroin use. Previously, she had tried a number of drugs, including amphetamines, LSD, and hashish. Cocaine was the first drug she injected. Soon after, she was shooting heroin as well. She felt that the relationship with her children's father revolved around drug use. That's basically what our relationship was, becoming high. Krista believed that the loneliness, depression precipitated her drug use. On a speed binge the summer before the interview, she remembered when she was 16, she had been raped by the Huntington Beach police while being arrested. She realized then that this was a source of her lifelong psychological pain. See, I had always remembered getting drunk that night and getting arrested, but I didn't remember being raped, and I remember now. I remember waking up at home beat up, 2 black eyes, a concussion, broken ribs. I mean, I remember that because I was beat up for weeks. Okay, now like I can remember those things, and it's made me feel like I know why I've been sad a lot. I don't feel like that anymore, you know. I mean, being sad a lot was why, and feeling lonely is a lot of the reason why I want to be high. So that's an example of the types of stories women are telling. I wanted to show this, this slide about how moms get started. We heard a little bit about it in Kristen's story, but when you start to see from 12th, this is a survey of 12th graders, and the source of their prescription drugs between 2009 and 2011. The fact that they can get any from the internet is not a good thing. So some of them get some from the internet. Mostly it's being taken from a friend or relative with no permission. They've stolen it. They've been given it by a friend or a relative, or they bought from a friend or a relative. And 85% of those prescriptions that they've obtained through theft, by giving it or buying it from friends or relatives, has been doctor prescribed. They get a prescription themselves. Look at the rates of, Look at the rates of prescription use of narcotics, non-heroin narcotics that kids in 12th grade are being prescribed. Okay? They're also putting themselves at risk a great deal of the time by getting them from a drug dealer or a stranger. And then there was a category of others. And down in this corner you can see the different types of illicit drugs that kids 12 years or older, starting at 12 years, are starting to get. And you can see that the pain relievers are the top ones. So that's what they're taking. And starting at 12, when we look at 12th grade, we also know that these are kids that engage in risky sexual behaviors as well, and more likely to end up being pregnant. They take complex care. Pregnancy is typically unplanned as a result of sexual violence. Because of the drugs that they're taking, they tend to have irregular menstrual cycles, so predicting and avoiding is a challenge, and pregnancies aren't necessarily as accurate when you have other drugs in your system. The responses that they have, they feel an awful lot of guilt and worry about their babies. They fear for their baby's health, of losing the baby, and they also are fearful of their partner's reaction, the father's reactions. Their happiness is a surprise. They do have some happiness at a chance to be a good mom. And to have kind of a socially sanctioned identity instead of being someone who dates or who is a prostitute, they can be a mom, which is far more acceptable. When they encounter the healthcare system, they face a lot of stigma. There is probably no more a reviled person than a mom who would take drugs while pregnant and harm their baby. They are kind of the bottom, of the totem pole when it comes to stigma. They brace themselves for the outcome. They go through periods of denial. They do actually try to do harmful reduction strategies. They may seek treatment. This is our chance. They may seek treatment. They may alter their lifestyle. Some of them try and do it by switching to a drug that they think will be less harmful to their baby. And many of them will try old wives' remedies to avoid the consequences of the drug. One thing that they report time after time is that one caring health professional can make a difference in their life. And again, I'm going to read you a couple of stories from Murphy and Rosenbaum's study. Once women were publicly identified, they were often stigmatized by labor and delivery staff. Clara, a white 32-year-old heroin user, explained why she failed to visit her child in the nursery. I didn't go one day to see him at the hospital because, I don't know if you know what nurses are like, but especially at a public hospital, they literally stood there and said, "Your baby's sick and you did it to your baby. We have really sick babies to take care of and you did this to your child." You know, but who could sit there for 12 hours a day with these nurses and their negative attitudes? In contrast, consider Jocelyn, a 26-year-old African American who was HIV positive. While she had certainly experienced discriminatory health care in the past, during her pregnancy, the nurse practitioner was extremely supportive. In a powerful endorsement for understanding healthcare providers, Jocelyn praised her doctor. "I know she is worried about me. If it wasn't for her, I'd be dead right now. People just don't understand. Just a little bit of kindness can do a fucking lot. It really can." Ethel gave birth to a son who was also born without apparent complications or withdrawals. During the first 4 months of pregnancy, she was not able to stop smoking crack, although pregnancy made her panic about her child's future. She recalled her emotional breakdown due to remorse after giving birth. "You know, I was using and this little baby was suffering, and I was using. And he had, I mean, it's like this little thing. It's like, how could you do that to him? It was so sad. And I had told God, I still feel bad about that, but I had told God to help me with this because I was like, I had asked him to give me a baby when he thought I was ready. And so I must be ready because I have my baby. And I asked them to take a test to see if they were toxic and if he was toxic. And the test came back negative. And I was like, yes. And Kay, her social worker, had told me she would give it to me. And it was like, oh my God, this is my baby. And it was so emotional. And at 3 in the morning, I called the nurse and I was like, I want my baby. And I just held him. He was sleeping and I over again, I'm so sorry. I didn't know what I was doing. And I promised to him that I was going to do the best that I can to be the best mom that I can be. And that's what I'm doing today, is the best that I can for today. But it was really hard. That was like the hardest part, was to see my baby and then know what I was doing. I had an abuse counselor tell me once that we really don't make changes unless we have a strong emotionally compelling reason to make change. The birth of a baby can be that moment of strong, compelling change. But we have to be there to be able to take advantage of it. They need that positive support. This is a statement by Lisa Tipton, who is Executive Director of Families Free, an organization in our area which helps moms who are or are trying to get clean. Some of them are court mandated with the new law in their Woven program. And she says, even if we have a magic moment with each mother, there isn't enough care for them. So even if they do reach that emotionally compelling moment, then we have to find them the care. And there's not a lot of care around for these moms, or just generally. So now I'm going to kind of turn to what's our situation in East Tennessee and who are the moms of these babies, because we certainly can't separate the moms from the babies in terms of the consequences for the babies and treating the babies. Just a show of hands, how many of you have actually ever seen a baby in withdrawal with NAS? There's a few of you here. I'm going to show you a video that CNN did with Eastern Tennessee Children's Hospital a while ago, a couple of years ago, about the babies and talking with that. I want you to kind of get a sense of what these babies are like.
This baby is 1 day old and he's going through withdrawal.
You watch his head.
Just a second, is that loud enough for you to hear? Can we make it a little louder? Just maybe a bit. I can hear the baby really loud. I'm not sure you can hear the narration behind it. Oh, I could look at the volume and turn it up. Okay, thank you.
Keep pretty good control of it. That's too stiff.
Knoxville, Tennessee is drowning in prescription drug abuse. And the babies here at East Tennessee Children's Hospital are the smallest victims.
We are transporting a baby for neonatal abstinence syndrome to the NICU.
Neonatal abstinence syndrome, or NAS, is the process of withdrawal in a baby in the first few days and weeks of life after exposure to certain medications in utero. What are the symptoms of NAS babies? What are they going through when they're born?
The common things that we see are a very difficult, hard to console baby. They're very uncomfortable. They have a characteristic piercing cry
Like we're hearing
that you hear
right
right now. They're very jittery, irritable. Sometimes they have seizures. Vomiting, diarrhea, difficulty with feedings is also very common.
Dr. John Buckheit says the babies here with NAS experience the same side effects as adults going through withdrawal.
You can see how she's modeled and how frantically she's sucking on her pacifier.
Since February, about half the infants here are NAS babies. They stay an average of 24 days. So what is she going through right now?
Right now with this baby, what you're seeing is she's having tremors. Her muscles are pretty tight right now. You can see how her arms are really just locked tight.
What's that called, hypertonic?
Hypertonic is what that's called.
Andrew Presnell works solely with NAS babies.
This increased muscle tone, you get 2 points.
The severity of their withdrawal is scored on a point system.
She's going to get more points if she is just laying there not being touched at all and she is shaking like she is now. She could get 3 to 4 points just from that.
2 scores over 8 points can send them to a special unit here. As babies go through withdrawal, they are extremely sensitive to noise and light. So the hospital built a wing of private rooms to accommodate the flood of NAS babies. But there still aren't enough spots for all the babies who need them.
Morphine is our drug of choice for the babies with the neonatal abstinence syndrome. I'm going to give the initial dose of morphine. We're starting her on 40 micrograms.
Since the epidemic is relatively new, there's no national consensus on how to treat NAS babies. Here, they give them morphine.
She'll know what to think about this grape flavor.
The babies get small but frequent doses because opioid withdrawal is extremely painful.
We put them on a small dose of morphine, and then over the next several days, or sometimes several weeks, we gradually decrease that dose and then wean them off.
They're gonna calm down. They're gonna calm down, girl.
Addiction to prescription pain medicine forces pregnant women, even those who want to quit, to make a painful choice.
I wasn't a good mom whatsoever. I mean, it was my addiction that came before anything.
April Russell has been fighting addiction to pain pills for most of her adult life. 2 years ago, she turned to methadone to fight her addiction. Why were you on methadone?
Because I didn't know what else to do, and I know that I needed help, to be able to stop my addiction.
Where's the princess?
Pregnant women who are addicted to drugs like crack are encouraged to quit. But with pain meds, the baby is just as dependent as the mother. If she quits cold turkey, the baby could die in utero from withdrawal. Guided by her doctor, April did what she thought was best for her baby and stayed on methadone for her entire pregnancy. The end result? Mariah was born dependent on drugs.
What did that feel like to know that your use of methadone had caused her so much suffering?
Oh, I can't explain it. It killed me. Still today, it's hard, but sorry.
A recent state health department survey found that about a third of pregnant women in state treatment programs are addicted to prescription pain meds. It's made the NICU unit here a pioneer in the treatment of dependent babies. Other states are looking to this hospital for guidance.
What do you think needs to be done to calm down this epidemic?
I think we as a society have got to get a better handle on the way we approach drug use, from prescribing, from the physician standpoint, from the use of narcotics from a patient or personal standpoint, and even from a legislative standpoint.
We're getting numbers and numbers of babies with the neonatal abstinence syndrome. If the babies continue coming here with that problem, we're going to treat them as necessary, and we're going to keep loving on them just like we are now. Looks like she's going to smile a little bit.
Amber Lyon, CNN, Knoxville, Tennessee.
Okay. And the problem they said about finding enough beds is something that we're experiencing in our area as well. And while JCMC is working to create a kind of zones for these babies who are going through withdrawal, there aren't enough beds, and so we're mixing, babies who are in the NICU because of prematurity with moms who did, everything right, did all their prenatal visits, were healthy throughout the things, working hard, mixed in with moms who feel like they did everything wrong. And it's not a very good social mixture, and the beds that are available for the babies with NAS, it's very hard to give them that that lower sensory input through lights and sound and interaction. So it's a challenge that's being felt across, not just at the East Tennessee Children's Hospital, but here locally as well. You heard them mention the Finnegan assessment. This is the classic assessment that is done with babies in the NICU who are, and outside of the NICU. Not all babies who are drug dependent at birth go into the NICU. Some of them are in the typical nursery if it's suspected that they'll have problems, and only move to the NICU if there's additional, more severe problems. So over the first number of days, about 8 times a day, they do the Finnegan score. And these are the characteristics that they're looking for in the babies with NAS. First is central nervous system disturbances. You heard the high-pitched cry. They look at the length of sleep following feeding. It tends to be shorter in these babies. They tend to sleep less. They're looking for the hyperactive moral reflex, which is kind of, if there's a sudden loss of support, how do they respond? They look for tremors, increased muscle tone. I don't know if you noticed when they pulled that baby up to sit, that head came right up with the baby, and that shouldn't be happening that early. There should be a lot of head lag, but because of the hypertonicity, that tends to happen. There's a lot of, their skin becomes very fragile, and so there's a lot of problems with excoriation, especially because they're moving a lot where their body is rubbing during their movement. They're getting skin excoriation. There's myoclonic jerks of the limbs, and they do have a higher incidence of convulsions and seizures. So those babies, in addition to maybe being on morphine for withdrawal, are also getting anti-seizure medications, such as Klonopin. They have metabolic, respiratory disturbance, vasomotor, such as sweating, hyperthermia, lots of yawning, mottling, which we saw in that baby, sneezing. Nasal stuffiness and sneezing is more common, as is nasal flaring and increased respiratory rate, and sometimes with retractions as well. These babies have gastrointestinal disturbances. They do with that excessive compulsive sucking. And yet when they're feeding, they often have an uncoordinated or disturbed sucking, so they don't feed very well. They tend to have reflux and vomiting, and this all resulting in loose, watery stools. The opioid withdrawal symptoms may appear as early as in the first 24 hours, but they also may take as long as 4 to 5 days to appear. So that's why babies typically in the typical nursery, they'll keep these babies in if there is a history of drug exposure. They'll keep those babies in for 5 days. And they may not have any problems, and they maybe could have gone home first, but again, increasing costs and length of stay, and the social problems of being there in your nursery with your baby for 5 days, watching for those symptoms preventively. There's a real wide variation in the reporting of how many drug-exposed babies actually do experience NAS, with estimates anywhere between 55 and 94%. They're trying to figure out why do some babies go through NAS and why do others not. Of course, they look at the drugs first to see which types of drugs may have been in that baby's system. It may have something to do with the mom's metabolism, how the mom's metabolism processes those drugs, and how the baby's does as well. It could be the gestational age and the amount of exposure at what point in embryological development. Those all may make a difference and are being examined. So not all babies exposed to drugs prenatally experience NAS. The question is exposure, even if it doesn't rise to the level of the baby having to go through withdrawal, you still can't imagine that the amount of drugs that they're experiencing in utero is good embryologically for future development. And so people are starting to look at babies that were exposed but may not have had NAS to see if they are any different in the consequences than babies who actually had NAS. So let's move to what we know about their neurological developmental outcomes. Okay. The most studied, of course, is prenatal alcohol exposure. We've been following babies with fetal alcohol syndrome for many years, and there's lots of good data on what the consequences of that is. It's been identified as the leading identifiable and preventable non-hereditary cause of mental retardation and other birth defects in the United States. Characteristics include facial dysmorphia, pre- and post-natal growth deficiencies, central nervous system dysfunction, general impairment in intelligence, deficits of attention, memory, learning, emotional regulation deficits, differences in brain architecture, hearing impairment, impaired reflexes, motor coordination difficulties, executive functioning deficits, delays in auditory processing. And so together, these different characteristics, which may all appear or some appear in different individuals, contribute to ongoing behavior problems. They have a higher incidence of ADHD, attention deficit hyperactivity disorder, I'm sure you know that, language and learning disabilities, and or hearing impairment that persist into adulthood. So we know a lot about fetal alcohol syndrome and prenatal alcohol exposure. When we get into the different drugs, we have less knowledge. And in part that's complicated by the moms themselves. The moms may have a drug of choice. And so when they identify that drug of choice as the one they take most of the time. But when that drug is not available, there are some who will not take something else, but many of them will depend on something else that they can take. And typically, alcohol, marijuana, nicotine, caffeine are pervasive through what they take. And they may not even think to report that because it's just kind of their baseline go-to, feel better until I can get my drug of choice. So take the data that we have with a grain of salt. I'm not sure in the long term that it's on an individual basis it matters as much what that drug was because of the complications of their social life, their behavioral life, their family relationships, poverty, and the fact that there may be other drugs that they were exposed to prenatally, depending on how regular mom's supply was. So, use of SSRIs. We have some evidence that there are subtle motor developmental differences. These children tend to have smaller head circumferences. Behavioral and social adaptability deficits have been associated with these prenatal exposures, maladaptive externalizing behavior, and increased likelihood of autism being comorbid with this. Whereas the current best estimate of autism is about 1 in 88. I've seen some incidence figures for this population as high as 1 in 44 to 88. I've seen any in those ranges. Use of methadone is linked to motor deficits, reduced social responsivity, and shorter attention spans. Prenatal opiate and cocaine exposure. There is just generally a consensus that these kids are at increased risk for neurodevelopmental impairment. The developmental difficulties that have been identified so far: lower weight, height, and head circumference, so again, growth issues, slower growth, and psychomotor deficits with some studies, and showing that these persist up to 10 years so far. And I say so far because the increase in this population just hasn't been studied that long in the longitudinal studies. These kids, some of these kids are up to age 10 now. We don't know beyond that because it hasn't been studied yet. Even under 6 months, there's a variety of subtle deficits across some or all domains of, the things that we can measure under 6 months. Orientation, habituation, which is highly correlated with IQ later on. State regulation, autonomic stability, reflexes, tone, motor performance, irritability, alertness, and excitability in less than 10 months. And this is when we put them with a new mom who may not be, who may still be using or trying to get clean, who is feeling bad about it. We're giving her a very difficult to handle baby. Looking at cognitive deficits, they've tracked these up to 18 and 36 months. Again, there's a limit on how longitudinally these kids have been followed, and they've been found to be less socially mature at 36 months. So we're seeing some differences. And continuing, there's a growing consensus around cocaine, though there's lots of variability in the literature, that prenatal cocaine exposure affects language development and contributes to receptive and expressive language delays, with particular deficits in the use of grammar, complex language, and discourse at 3 and 4 years. Neurodevelopmental compromise of the auditory system appears to result from gestational exposure to cocaine. And they're seeing actual physiological changes on testing for ABR and IPL brainwaves. We have very, very little information about the neurodevelopmental outcomes for kids exposed to meth prenatally, but some evidence is suggesting that these children are showing similar outcomes. Prescription drug exposure. Did we talk about this already? Yes. Sorry, this is a repeat slide. Okay, so that's it. That's all we know about these babies because they're so new on the scene, and funding is not readily available past NAS. It's like we've cured them of their dependency on drugs. We're done. But we're suspecting that we're not nearly done. We don't know what's happening with these babies. What we do know is these children born with NAS demonstrate ongoing neurodevelopmental difficulties beyond the initial perinatal medical symptoms and their social fragility. What we do know is that many of the impaired systems and skills are closely associated with behavioral, social emotional, language, learning, and auditory processing. And we desperately need to obtain data about this growing population's long-term outcomes, which we don't know a lot about. There's treatment challenges. Access to early intervention services can be compromised, partly because the services are unavailable. Kids can often not qualify because their symptoms are not severe enough to meet the criteria of deficit immediately following birth, or there's just poor coordination of services for these kids. Here's a couple of stats. In East Tennessee, the rate for those 12 and older who need but do not receive treatment for illicit drug use at 2.51% exceeds the rates for the state and is equivalent to the national average. We do a little bit better for alcohol, being less than the state rates and national averages. But part of it is the social complexity. The mothers with or recovering from substance abuse are difficult to engage. The complexity of the social and medical problems, the high risk for continued drug abuse, and their perceptions about how others will react to them leads them to avoid contact with health and educational agencies. As I was saying, it's difficult to identify the effects of individual drugs because of polysubstance abuse. There are environmental risks of this population, low socioeconomic status, poor prenatal care, transience. Some of the moms that I've worked with across a 3-month period have moved 3 times. So mostly being evicted as much as anything else. So it's not an easy transition for them either. And sometimes identification of primary caregivers is a challenge. These kids may go in and out of foster care or in and out of the care of other family members during those early stages. There's also this period, again, immediately following their withdrawal from the drugs, the completion of the NAS treatment, where there's this kind of period of illusory recovery. It seems like they're doing okay because a lot of stuff, development is really reflexive and doesn't involve learning early on. And so they drop out of the system or fall out of the system, and then it may be hard to re-engage either the caregivers or the child. And so it's only later on do those social, emotional, behavioral, language, and learning consequences emerge once they're in school and their teachers are having a hard time managing them in school. The teachers may or may not know that these kids were drug exposed because it isn't information that people willingly share. So they just know they have this very odd child in their class who is hard to handle and who isn't learning well without understanding where that might be coming from. And they may have parents or family systems that are difficult to engage with. So babies may fail to qualify from services or be discharged before early detection or problems are observable. There is, Banstra and his colleagues created a model of care. This I focused, the yellow is kind of for speech pathologists and audiologists, but you can see where you may fit in as well. There's a lot of role for individuals in your profession as well to contact and engage and in an interprofessional way link with others so that there is a continuum of care and a holistic set of care. So what are the implications for caseloads of these kids on working professionals? Well, in our corner of Tennessee, from our 2 health units, we can expect 208 children with NAS to enter kindergarten in 2017, 216 children with NAS to enter in 2018, and so they should say 174 plus children with NAS to enter kindergarten from in 2019 because I only have the data up to last week. We won't know who all of them are. Well, they'll just be referred to us, and we may or may not know that they experienced NAS. We won't know how their behavioral, social, emotional, learning, speech, language, and literacy characteristics will present because we don't have that data yet. And we don't actually know how to treat them quite yet either, because we don't have an evidence-based practice load. Though we are certainly getting some anecdotal information from clinicians across the area that these kids look like other kids, but they're not responding to the same techniques in the same way as other kids. So some of these kids, the occupational therapists are reporting some of these kids have pretty significant sensory difficulties. But when they try the techniques that they've been using with their kids with autism, these kids are not responding in the same way. So there's not an easy transference, even when we focus on the symptoms of these kids. So we've got to work together and share our knowledge. The last slide is the citations I used in this presentation, plus some additional references and resources that I found on this population. So we've got about 10 minutes for questions, and I'd be happy to answer what I can. I think somebody's coming with a mic.
Well, thank you very much for addressing this really important topic. I have a comment and a question. My comment is that the use of SSRIs, it's really a complicated issue because there's a large body of evidence that untreated depression during pregnancy also affects the baby, so there's no option without risks. My question is, what do you know about any evidence of the effect of detoxing the mother during pregnancy on the baby?
That's a really good point, and it's the same with the Subutex, the Suboxone, the methadone. Is we have to keep the levels up high enough that the mom's not going to seek stuff elsewhere, but it's at a higher level than of toxicity for the baby. It's always a really difficult balancing act to take care of both the mom so that that doesn't get worse and have other negative consequences on the baby, and keeping it low enough that the baby may not be as harmed. So I'm glad you brought that up. The second part of the question, which was, sorry, I forgot now. Right. Detox. That is a big question. I mean, the general belief out there is if you detox during pregnancy, the risk of miscarriage becomes much higher. But that hasn't really been very well experimentally tested. I know that there's a few doctors in the area who do not believe that that's true, that if you do detox these moms in a very closely monitored and controlled way, it may be that we can successfully detox them without additional harm for prematurity and that. But they're just starting to look at those studies, that information, and trying to see what we can do to do that. So there's a big need for that type of research to happen. Mm-hmm.
I know it's obvious, but just to make sure it's pointed out, when we think about detoxing in the situation you just mentioned we're in, you might do it during pregnancy. We're not doing a detox as we usually think of it,
right,
which is usually admit the person, get them. We're talking about a very, very slow taper over months. Is that what we're referring to?
Yes, that's my understanding
as opposed
as well.
to the more acute, which would create a hyperadrenergic state and increased risk, that kind of thing.
Yeah, that's my understanding as well.
Do we have any evidence of opposite outcomes for NAS babies? For example, an alcohol baby who is highly intelligent, however, highly socially incompetent.
The question of resilience is always an interesting one. I don't know of any particular studies saying, yeah, this is good for them, or that some babies are, do fine. I mean, a lot of individuals my age, our moms smoked all the way through our pregnancies, and some of us are doing pretty well, although I always say to my mom, I could have been so much more intelligent. So we have kind of social histories of those kinds of things, or moms that drink, and some just seem to be more resilient, and not all baby. Even if we compare moms who are at the same level of taking a particular drug during pregnancy there may be very different outcomes for how severely their baby is affected, whether they have NAS, don't have NAS, and the severity of the NAS. And we're still trying to there are people who are trying to figure out what are things that contribute to predicting who is going to have more difficulty than others. So I don't know, looking at the resilience literature would probably be the best way to go. We have it for poverty and things like that right now, but not necessarily for drugs that I know of.
Thanks. I've seen a lot of these presentations. This was a really nice compilation of kind of the national problem and our local regional problem. And just one comment, the numbers for NAS and children going to kindergarten, that's alarming, but actually that doesn't really capture the amount of babies that are being affected that just don't even show the NAS. So I think it's even more of a crisis than those numbers indicate, because every baby, as you said, isn't having NAS symptoms, but their little brains may be very impacted, and when they get to school, we're going to see this. So I think it's really going to be more of an issue for the educational system, maybe than even those numbers. And the other thing is the complexity and the need for prescribers to be really working closely with women of childbearing age on birth control. We had some data a couple of years ago about how many providers or prescribers were not discussing it, and I know that there's a checkbox now on some TennCare forms and things, but I think that really is a prevention strategy that has to be looked at, and prescribers working more closely around obstacles to access and use and methods that would help with this epidemic too.
I agree with you. I mean, of course, the long-term solution is prevention of it happening in the first place. And we have this sense that because it is entirely preventable, we should be able to entirely prevent it. Human nature being what it is, but maybe we can make gains in that area. The trouble, and a lot of people are doing some really good efforts in this area to do that. One of the things I noticed in this year's stats of the area is that Sullivan counties have come down by about 2% over the last 2 years, and they've been really in the forefront of trying to deal with prevention, with extended birth control methods, drug take-back events, lock boxes in homes so that it can't be stolen. They're right at the forefront, and it is having some impact. So overall, we're down about 2 to 3% over the last year in our area, but most of that is happening in Sullivan County.
Thank you for the wonderful presentation. The question I have is whether or not you're aware of any neuroprotective strategies that have been employed, any studies that have been considered or even employed in NAS neonates and thereafter, such as the use of SSRIs. I know this is not indicated, but just because these are higher risk babies.
You'll have to clarify for me what you mean by neuroprotective strategies.
Any range of medications that may be employed for protecting the brain.
I'm not aware of any.
And
as that was a new term to me, now I'm going to keep my eye out for it, but I may not have been looking for it. So
the other thing I wanted to ask you about is if you're aware of, like in Afghanistan, what has been typically employed among the indigenous people in the mountains is that they will actually take a tincture of opioids and I guess they inhale it and they spray it. They blow it into the faces of their neonatal their neonates to calm them down. I'm just curious what thoughts you have about that relative to the
I mean,
NAS.
right now it's a preventive. They talk about breastfeeding as part of a preventive strategy as another way to encourage some breastfeeding of moms who may still be on that as a way to soothe and calm is one strategy that's being examined that might kind of fall into that category of prevention, but mostly we're relying on morphine is the primary one at this point, so I don't know of any other strategies.
So I noticed in your presentation that there was a number that was very interesting to me, that the rates of opiate addiction are increasing nearly twice as much as the rates of neonatal abstinence syndrome. And I wondered if you had any thoughts about what that means.
Just that maybe the incidences are across the entire population as opposed to just across the moms. I mean, that might be it. So that we're not seeing as great a consequence there. Maybe we're getting better at preventing pregnancy. Those are my initial thoughts. I don't have anything specific in response to that, but that's an interesting observation.
Thanks, really great presentation.
Tennessee is called the epicenter of the nation for prescription drug abuse. So the numbers are increasing across the population. Maybe mums are getting the message, or potential mums.
Just an additional observation and comment, following up from what Dr. Moser said. You would think that we as prescribers would be good at monitoring women who are fertile, but actually we're not. And it's a critical issue that any time a medication is prescribed, that we understand the woman's birth control plans, and so on in relationships. And this is an issue nationally, such that the APA is currently generating an opinion paper and education for psychiatrists, because this has been recognized as a deficit. It's something that in the residency and amongst faculty we continue to be very careful about.
Well, I mean, you really are in a position to make a real difference about the prescription of these drugs that affect these babies so much that, it is something to be very careful about. I just received on Tuesday a handout that was developed for physicians of moms or potential moms on drugs, that has pamphlets in it for the moms, plus kind of talking points for the parents, that came out of the NAS task force meeting yesterday, or on Tuesday, at the at JCHC. Mountain States and MISHA Mountain States and Wellmont are collaborating on a task force that's been running for over a year, focusing specifically on NAS, and always is welcoming new members. But there was this really good handout that was involved in that might be helpful too, educationally. So they are trying to get the word out.